First thing is that I think um, I'm going to say a few things before I jump into the talk itself. And the first thing is that I think it is very important for everybody on this Zoom session to understand the outline of how we approach Syncope, because my approach to it has evolved greatly over the past quarter century. And I think I'd like to share sort of the framework that I use when I approach Syncope. And I will tell you ahead of time, and you'll see from my mistakes that you have to approach it with a lot of humility. It is really humbling to take somebody who's passed out and guide them through how we approach it and what we can do to keep them safe. The second thing I want to say is that by design, most of my lectures are fairly interactive. I like to call on members of the audience. If there are times when maybe I'm jumping through things and people will stop and say, let's explore that a little bit. It's much harder to do that on Zoom. I've learned that the hard way. And so I don't anticipate selecting members of the audience and asking them questions necessarily, although by nature that's my style. I think there will be times when you all can either reach out through the chat or just interrupt me and say, you're going too fast, I'd like some clarification. And that's fine. The main thing I want to do is make sure that everybody here feels engaged. So with that, I'm going to start out with a case that really kind of stumped me for a while. And this is a true story. It happened right here. 73-year-old guy, known coronary disease, previous bypass grafting, came to the emergency room with this third episode of exertional syncope. So as you can imagine, our antennas are way up. We're thinking exertional syncope, that's a big deal. We want to do something. He's a heart patient already. He's got bypass surgery, high risk. So naturally, he was sent home and scheduled for a stress test. To a great extent, we can wonder about the wisdom of that. I'm not 100% sure he needed to be admitted, but I will say that sounds like a high risk situation. And we can talk about the utility of a stress test. It's usually not the first thing we go for when somebody truly loses consciousness. At any rate, the stress test is done in our office, and it stopped early because he has a symptomatic 2-second pause. Now, I'm sitting here, I'm an electrophysiologist, like a 2-second pause. We yawn at that. That just doesn't seem that interesting. But it was stopped early, and he was sent directly to the hospital, admitted to telemetry. And he underwent a cardiac catheterization, which revealed patent grafts and preserved left ventricular function. He underwent an electrophysiology study, and he had no inducible arrhythmias and no straightforward evidence of conduction system disease. So the question we had to ask ourselves at that point, is there a next step? I mean, this guy has gotten what feels like the kitchen sink thrown at him. He's passing out, and we really, at this moment, don't know the best thing to offer him. So with that, I'm going to talk about the way I approach syncope. And the first thing I'm going to tell you is that these are the goals that we have when somebody walks into our office with syncope. And the first is screening for more dangerous conditions. Okay, and that seems obvious, but I'll just say it. When somebody passes out, there are a bunch of questions that should be going on in our heads, but one of the bigger ones is this a sign of something worse that could happen? Is there something that, if left untreated, could lead to death or permanent disability? The second is nearly as important, reducing the likelihood of further events. Syncope is bad. We want to avoid it. What can we do to lower the likelihood of another event? Reassurance is important in the right circumstance. A lot of people who pass out are very concerned that it could happen again, or that it's a sign that their body is failing. We have to reassure them. And finally, education. We have to educate them about what had happened to them and what are the ways to avoid syncope in the future. Here's the unrealistic goal. And I will emphasize this as often as I can. I have avoided telling patients that we'll, quote, get to the bottom of this, or that we'll figure out what's up. And that seems at first a little bit paradoxical. I mean, we're throwing the kitchen sink at them. Why can't we figure it out? Well, I'll explain why. There have been innumerable studies, most of which have come out during my years of practice, which showed that if you perform a comprehensive evaluation for people who have lost consciousness, regained consciousness, and feel well, a third of the time you do not find a cause. Okay, a third of the time you cannot figure out what caused them to lose consciousness. Now, it turns out that these patients have a good prognosis. And because you all live in the same world that I live in, I can see the gears turning in your heads right now, even through Zoom. Half the patients, if you tell them that, will say, thank God they didn't find anything bad. And the other half will say, I can't believe it. You mean I drove all the way down to Scarborough and I saw this guy Carpenter who seems to know a lot about syncope, and he did all this stuff. In the end, he said he doesn't even know. I mean, you know, what do I do next? That's our job. Our job is to educate them. Our job is to reassure them. Our job is to make sure they don't have anything bad. But I also think we need to temper expectations when we first meet them, because none of us are that good. So I'm going to pause for a sec to talk about, quote, neurologic causes of syncope. Technically, a seizure is not categorized as syncope. Syncope technically means that your brain does not get enough oxygen, does not get enough blood to function, and you lose consciousness. That said, a seizure is always going to be in the differential diagnosis. And we're actually going to expound on that a little bit more as we go along. The second thing I want to say is cerebrovascular disease as a cause of true syncope is very, very rare. And I think every study that has looked at this in detail has come out with the same conclusion. So it is not at all unusual, even in this era, after all the studies have come in, for somebody to pass out and for them to get ultrasounds of their carotids. Maybe they don't have enough blood flow to their head. In general, severe carotid stenosis presents, well, I'll ask you guys, what does that usually present as? What are the symptoms? Okay, so this is why this is why Zoom calls are hard. Usually, if you're sitting in a lecture hall, there are 3 people raising their hands or yelling something out. But the most common way severe carotid stenosis presents is transient monocular blindness. And in any event, the symptoms associated with critical carotid stenosis are lateralizing. So it's not somebody has a loss of consciousness, awakens, and has no neurologic sequelae. Okay, so I'm going to stick with how we go about taking care of syncope. So the important thing here, and it's interesting because I literally yesterday saw a note from Andrew Corsello in which a patient had lost consciousness, and after doing the initial evaluation, the first thing he did was call the patient's wife to get her account of the whole thing. And I thought that's really Syncope 101 right there. So history is really, really important. And I'm gonna actually sit on that for a second, because it really helps how we take the history. And I'll give you an example. If you sort of ask an open-ended question in the office, which we're trained to do, and you say, tell me about the events of your losing consciousness. It is not unusual for somebody to say, well, I was talking to my wife, and the next thing I knew, things got a little bit gray. And then I don't know what happened, and she was talking to me, and then the EMTs got me and took me to the hospital, and they said I was fine, and I went home. And that is your answer to the open-ended question. What are the sorts of things, and I will ask for audience participation here, if a person has had a single episode of syncope, concerning, they're sitting in your office, what are some of the questions you might ask them?
If they had a feeling of pre-syncope?
Say that again?
If they had a feeling of pre-syncope?
Right. So one of the more important things you're going to ask is the prodrome. And so that's really helpful. Since you guys are answering these questions perfectly, I'll ask another. What kind of prodrome, what are the sort of sensations you might feel before an episode of sort of classic vasodepressor syncope?
Like tunnel vision, or like patients will describe auditory, like ringing or muffling of noise.
Right. So in general, if you're losing blood flow to your head, you'll get tunnel vision, you get graying out, you get muffling of noise. The things that sort of help us to say there was a vagal stimulus, there was the brain sent out something that was vagal, was sweating. There are a lot of GI symptoms. You can feel like you're about to throw up, the urge to defecate. And each of those things separately can sort of push us towards saying, it sounds like there was a vagal quality to that episode. One of the things I always ask is, what time of day was it? Had you had coffee? Have you had breakfast? Were you standing up? Were you working out in the yard? The things that may predispose us to a vagal episode: dehydration, unusual stimulus, upright posture. And I think that each of those things in and of themselves can be important. Yes, standing for long, upright posture for long hours is a big point. So we obviously are going to do a good physical exam, and we're going to look at the electrocardiogram. So in this era, most of the people who move here can't find a house, and we always say the main thing when you're buying a house is location, location, location. In a syncope evaluation, it's conversation, conversation, conversation. And this is one of the debriefing things that I have to go through in fellows clinic all the time. So it's not unusual for a first-year fellow to come in, this guy passed out, and he or she is saying, well, we got to get a Holter, we got to get an echo, we got to call EP. And I redirect them and say, let's talk to the patient. Let's hear the story. So again, when we're talking about the history, if we're going to drill down, what are the things that are really important? We have to know the milieu in which it happens. What is this person's physiology? So you're going to get a detailed medical history. Medication history is really important, especially new medications. and you want to ask about previous events. This is a really good example of one of the mistakes I made. And again, if it sounds similar to the first patient, I apologize. The only things that are similar is that I was taking care of the patient. So there was an elderly gentleman who had recurrent episodes of exertional syncope, and he'd usually be hiking in the woods with his younger wife, and next thing you know, he lost consciousness. So we threw the kitchen sink at him, we hospitalized him, put on him telemetry, did an echo, electrophysiology study, and really didn't find anything concerning. And it turns out that one of the nurses on R7 actually sat down and talked to the patient and his wife. And it turned out that years ago, he had been, he had walked into an emergency room and said, I get really short of breath when I exert myself. And they had said, that's angina. Next time you have that, take nitroglycerin. So it turns out that he would be hiking in the woods, which is with his much younger wife, and get more shorter breath than her. And the two of them would do as he was told, and he would stop and take nitroglycerin and promptly lose consciousness. And it turned out that that was purely, that was purely a reaction to the vasodilatation that comes with exercise and nitroglycerin. And had I taken a good history in the first place, I wouldn't have put him in the hospital. I would say, don't take nitroglycerin, and everybody would have been better off. So tracking down the eyewitnesses is really important. Bear in mind that the one person who has no idea what's going on when they're unconscious is the unconscious person. So to the extent that you can find eyewitnesses, that can really help. So when we talk about the events themselves, we're going to talk about triggers. We're also going to talk about incontinence. So I'm going to just dwell on that for a second. So benign forms of syncope almost never cause fecal incontinence, rarely cause urinary incontinence in men. Okay, tongue biting. Why do we ask about tongue biting? Right, so tongue biting is more likely, much more likely to be a sign of a seizure than cardiac syncope. And here's the question I ask every single time. And I think it is, I cannot overemphasize the importance of it. How did you feel when you regained consciousness? So I'm going to dwell on this one for a second because it's really important to me. So if people are truly confused, combative, they don't know where they are, that's more likely to represent a seizure. If they're transiently confused and they're weak afterwards, overall okay, but just feel like they can't quite clear their head and not feeling too well, that's more characteristic of a vasodepressor syncope. And if they literally feel fine, if they're like, what happened? I'm fine. What's everybody doing here? That is the most characteristic of a cardiac arrhythmia. And you will see this in the hospital. There will be times when people will lose consciousness due to transient high-grade AV block and not even recognize it, or to an episode of non-sustained ventricular tachycardia, because the minute sinus rhythm is restored, they feel fine. So common triggers for vasodepressor events, volume depletion, I cannot overemphasize that. Hunger, posture, so standing upright for a long time, and pain. So if somebody has something drop on their foot and it really hurts, you get a splinter underneath your fingernail, you're quite likely to have a vasodepressor event just from the pain. Okay. Now we're going to talk about family history. Yeah, strain, that's exactly right. So we're going to talk about family history, and I think that this is really, really important. We've been talking about trying to figure out the cause of a patient's syncope, but one of the things we're always doing is screening for more dangerous forms of syncope, and so we really need to know, and I will specifically ask them about each of their relatives. Are they alive? Did they have concerning episodes of syncope? Did they have sudden cardiac death? One of the more interesting things I've run into, and you guys probably have too, is that it is rare for somebody to say, my father had an unexplained cardiac arrest at an early age. The term they almost always use is massive heart attack. So it probably wasn't a massive heart attack. You know, the guy was sitting in his chair and dropped dead, and they didn't do an autopsy. But that right away pushes this patient into a very high risk group if they have a first degree relative with sudden cardiac death at a young age. And we're going to go into that a little bit more. So again, physical exam, I'm not going to belabor this because you guys already do a very good job at this. We're going to check the vital signs, orthostatic vital signs, differential blood pressures, and a murmur. So in the EKG, what are the things that what we might be looking for in the screening EKG? Person walks into our office, they've had an episode of syncope, you're concerned that it may be a sign of something worse. And I'd just like to hear from the audience, what are the things we're looking for on the resting ECG?
Heart block, pauses.
Yeah. So if you, and by the way, if we find that on the screening EKG when the MA does their ECG and shows it to you, we're all set. We rarely do, but if we do, we can give them, we can tell them the answer even before we walk in the room. So that's one of the things. What other sorts of things?
Delta wave.
Delta waves, that's very good. So delta waves are a sign of Wolff-Parkinson-White syndrome, which is its own, can cause both rapid heart action and in rare circumstances, syncope. Those are good.
Chuck, people are also putting in the meeting chat too that don't have audio.
Oh man. So yeah, we'll get to that's a very good point. EMS strips are very important, and we're going to go back to primary data in a few minutes. That's good. So the things that I'm hoping for on the 12-lead ECG.
I'd say
Who
long
said-
QT and possible like Brugada changes I'd look for too.
Oh my Lord. That's very good. So let's go through that. The sort of catechism I use, the things I try not to avoid missing, I still do. Pathologic Q wave. So it is hard. I'll just tell you ahead of time. It is hard to pick up MIs on a resting EKG. There are a lot of sort of small Q waves in the inferior leads, which may or may not represent an inferior MI. The computer routinely overcalls anterior MIs. If people have QS complexes in V1 and V2, they call it anterior MI. But there are going to be people who have honest to good MIs on their resting EKG. And anybody who's had a transmural MI and syncope is at risk for VT or worse arrhythmias. So Q waves are important. Conduction system disease, so that really comes in sort of couple flavors. First three AV delay, left bundle branch block, right bundle branch block, and along with right bundle branch block, either left anterior, left posterior fascicular block. Those will push you hard in one direction. Those will push you really hard. If a person has episodes of syncope and conduction disease on his or her resting EKG, you already have a high suspicion that this person has transient high-grade AV block. QT prolongation is really important. Anybody who has honest to good QT prolongation and syncope is at risk for what, sorry about that, is at risk for what particular form of syncope? It's a French word. Okay, so torsades. Okay. Lord, I don't know what to do exactly about this dog right now. So can anybody tell me about Brugada syndrome?
I can say some things about it.
I'd love to hear it.
It is a channelopathy. I think it has to do with the sodium channels, and I can't remember if it's like an overexpression or underexpression.
You're absolutely correct.
It's more commonly seen in men.
Mm-hmm.
You can often elicit Brugada changes with like a fever, or with procanamide,
right?
Sodium channel blockers, I guess. And it predisposes people because of the way that those sodium channel works. It creates kind of like a heterogeneity, like it changes the repolarization in the ventricle in a way that it can predispose people to ventricular arrhythmias and sudden cardiac arrest. And it would be, you have two different changes that you'd be looking for in the EKG, like Brugada 1 and Brugada 2, and one is more doming in V1 and V2, and one is like a saddle.
Well, so you guys, Kennesaw just gave us a seminar in Brugada, so I'm really not going to add anything else. That is incredibly comprehensive. The interesting thing about Brugada is, compared to how often we look at it, it's incredibly rare. And I think it's also hard to diagnose. If somebody has the classic saddle-shaped deformity. I'm trying to get my dog outside. Sorry, Mark. If somebody has a classic saddle-shaped deformity, in the right precordial leads with an incomplete right bundle branch block, it's easy. Most of the time, you know, and Kennesaw said this, it's a dynamic process. So depending on what drugs they're on, whether they have a fever, whether they're ischemic, it will be there and then it won't be there. Once you consider Brugada syndrome, it is very important to follow through on it. The gold standard these days is actually a procanamide infusion test, which in and of itself can be difficult to interpret as well. So I don't pretend that there's a single best way to do it, to look for Brugada syndrome. I think the most important thing to remember is that it's very rare. So, sorry, technical difficulties here. When we talk about family history, what are the other things we're going to screen for? We've talked about long QT a little bit. We talked about Brugada. Hypertrophic cardiomyopathy is very good. And there's another rare entity called arrhythmogenic right ventricular cardiomyopathy. What do you all know about that? Okay, so I'll talk about arrhythmogenic right ventricular cardiomyopathy. First thing to remember about arrhythmogenic right ventricular cardiomyopathy is that it is familial. There is a genetic test. Not everybody is gene positive. And it is characterized, well, actually, we'll talk about that a little bit more. I have some slides on that. So now I'm going to talk about vasodepressor syncope. And this is something that each of you is quite familiar with. Vasodepressor syncope is the most common cause of syncope in healthy people. And it represents a sudden fall in the blood pressure. It's usually accompanied by bradycardia, and it's always due to increased vagal activity. It comes with a bunch of different names: neurocardiogenic syncope, vasovagal syncope, micturition syncope, situational syncope, parotid sinus hypersensitivity, and it goes on. And I think you guys probably know this, but I'm much more of a lumper than a splitter. They all have the same physiology, and that is there's a dramatic outpouring of the parasympathetic nervous system. And historically, the hallmarks of vasodepressor events are recurrent episodes, situational episodes. So, and I think that this is really, really, really important. When people are describing their episodes, and they say it happens every time and you fill in the blanks, that cannot be an arrhythmia. Arrhythmias by their very nature are random. So if somebody gives a history in which certain things trigger their syncope, you're already thinking about vasodepressor events. Recurrent episodes are really important. So statistically, if somebody has had 4 or more episodes of syncope without sequelae, the likelihood that that's an arrhythmia becomes much, much, much lower. So, the more malignant forms of syncope usually only have a couple chances to get it right before it actually leads to death or disability. The prodrome we've talked about. Here's the thing that's really important. For those of you who have performed tilt table tests, you already know about this, but even after people regain consciousness, there is still a lot of parasympathetic outflow. And for that reason, they don't feel that good afterwards. Even after they've regained consciousness, even after their blood pressure, let's say that they're supine, but their blood pressure is okay, they still feel weak. They still feel ill. And depending on the episode, they may feel not quite right for the rest of the day. And I think, one of the classic sort of things we see a lot is a guy will pass out. He'll slump to the ground. As he's lying on the ground, the blood slowly gets back into his head. and he looks up and he sees everybody staring at him. He says, "I'm fine," and he stands up and he passes out twice. And that's because he's still vasodilated. He's still relatively bradycardic. So people do not recover abruptly from vasodepressor events. If we talk about seizures, this part is really important. Tongue biting is important. Head turning to one side is important. Witness tonic period. So I demonstrate this in the classroom. I can't, but it is very common for people who have syncope and not seizures to have a clonic period in which their limbs are shaking just as in a seizure. But a classic tonic episode in which people suddenly their head turned to one side, they are tensing their muscles, that's seen in a seizure and not with cardiac syncope. Abnormal behavior, either before or afterwards, people who have a smell that nobody else can smell, or visual hallucination, and especially post-ictal confusion. Those are all characteristic of a seizure. If you have cardiac syncope, the things that really push you towards an arrhythmia as the cause of syncope is unheralded syncope, random events, or at times exertional events, and prompt recovery. Okay, once sinus rhythm is restored, people tend to feel fine. So I'm going to talk about orthostatic hypotension just because it's always in the differential. And if people have recurrent episodes of orthostatic hypotension, there's almost always some degree of autonomic insufficiency. And there are different ways we can get there. Elderly people, just by dint of their aging, will have a little bit of orthostatic hypotension. It's a matter of their peripheral nervous system, their autonomic nervous system becoming a little bit sluggish. So when you're 35 and you're sitting in the bleachers and you don't hydrate yourself and you stand up suddenly, you're going to feel lightheaded for a second and then you'll recover. If you're 78, you may pass out in the same circumstances. There's going to be some people who simply have autonomic insufficiency. Things that affect your peripheral nervous system, like diabetes, are going to be more common in people with orthostatic hypotension. It's occasionally seen in adolescents, and thankfully a fair amount of them will outgrow it. It's very easy to diagnose, and as each of you know, it's very hard to treat. You can overlap with vasodepressor syndrome. So people who are prone to orthostatic hypotension will have decreased filling and can have, in addition to orthostatic hypotension, an honest to God vasodepressor event. Okay. So malignant arrhythmias and structurally normal hearts. We've covered a lot of them. I'm just going to go in a little bit more detail. Long QT syndrome, ARVC, and Brugada syndrome. So long QT syndrome, I think it is when we're studying for boards, it's very easy to understand. When we're taking care of patients, I think long QT syndrome is very murky. Usually you'll have a corrected QT interval greater than 480 milliseconds. Bear in mind that this is literally a bell-shaped curve. So there are two things to bear in mind. First of all, it is hard to measure the QT interval. That's already been documented. The computer will get in the ballpark, but it's not always correct. And if we look at the studies, even cardiologists, there's a little bit of a bell-shaped curve to where they actually measure the end of the QT interval. The corrections are good in rates of about 50 to 90, and then they get a little bit skewed that way. And bear in mind, QT prolongation is a dynamic process. So even people with long QT syndrome and torsades will have variability in their resting QT interval. So it's got to be murky. I'm just going to say that out loud. It's really tough to know how to treat somebody with syncope and suspected long QT. So familial long QT syndrome is well documented. We at Maine Health Cardiology, there's some very famous families who have had patients who've passed out, patients who've had ICDs placed, even patients who've had sympathectomies. In general, the familiar ones are easier to figure out. Acquired, this is, and again, I believe that most of the people with acquired long QT have a genetic predisposition, but it's a dosage effect, meaning that they don't have the genes that cause them to have a long QT at baseline. But if they're exposed to, let's say, azithromycin or haloperidol, their QT interval becomes long and they're at risk for syncope. Today, the simplest reference for QT prolonging agents is the Credible Meds app. So when I was growing up, we used to give patients a mimeographed sheet of paper showing them all the drugs to avoid, which was silly because at the moment that piece of paper was printed, there were new drugs on the market and it was already out of date. ARVC is rare. It is familial. There are genetic tests for it. Not all people with ARVC, though, are gene positive. Here's the thing that's really important. In the early stages, these people will have normal echocardiograms and normal ECGs. At Maine Medical Center, the best test we can do to screen for ARVC is a cardiac MRI. Brugada syndrome, I think we've covered this. I'm just going to give you a picture of classic Brugada. Now, this is what Kendall was referring us to type 1. It's not really a right bundle branch block. It's an incomplete right bundle branch. And you see the dramatic J-point elevation in the right precordial leads. And that is classic for Brugada. It is very rare. So I'm going to switch gears now, and we're going to talk about further testing. And here's something that I'm going to emphasize time and again. There are 3 categories of testing for syncope, and one is correlation. So you can actually say this person is having an arrhythmia at the time that they're having their event. Okay, correlation is the best. Coexistence, okay? So you have a person, you know, in coexistence, the classic coexistence for me is the guy who's visiting from Connecticut, goes to DeMillo's, he falls into his chowder, he wakes up, they bring him to the emergency room, and he has first degree AV delay, right bundle branch block, and left anterior fascicular block. Now, you haven't correlated anything to his episode of syncope, but the coexistence of that degree of conduction system disease and unheralded syncope is a class 1 indication for a pacemaker. So despite correlation, you still have a good idea why they passed out. And Gene Cass brought this up earlier, but aortic stenosis. So let's say a guy has recurrent episodes of exertional syncope and has critical aortic stenosis. You're not going to look for a second cause. You have found it, even though you haven't correlated it. The worst category of all is provocation. Okay, I'll say it twice. The worst category of all is provocation. So for example, tilt table testing, electrophysiology study, and I will give you examples of times when provocative tests have led people to the wrong conclusion. Okay. So ECG monitoring, I think that all of us are very familiar with it. In fact, it's to some extent, it's become kind of a reflex. Guy passes out, okay, we'll do a Holter. it can be really difficult to get a graphic strip of the arrhythmia that you're looking at simply by slapping a Holter on, or any type of monitor. If we look at the types we use, and again, as we're transitioning to patch monitors, some of these categories are a little bit, the lines are more blurred than they used to be. But putting a monitor on somebody for 24 or 48 hours is very, very, very unlikely to find the cause of an episode that happens, let's say, every 3 to 4 months. An event monitor will be higher yield. And implantable loop recorders, simply because they're checking people all the time, will be the highest yield. Now, let me ask you this. If we talk about implantable loop recorders, are we going to get false positives? Is there a time when the loop recorder is going to say this person has a funny arrhythmia? He's going too fast or too slow, and yet it's not tied to syncope?
Yes.
You're right. Yay. Hey, Melissa, how are you? Yeah, you're absolutely right. And I'm going to explain why. So if we put a monitor in and we use the factory settings for syncope, we will usually tell them that, let's say, there's a pause of 5 seconds or longer, or they're bradycardic down to 30, or we're screening for a tachyarrhythmia, and you decide, you put the heart, you say anything faster than, let's say, 150 beats a minute. Well, people can have 5-second pauses while they're sleeping. People's heart rates can go down to 30 while they're sleeping, and they can be completely asymptomatic. And likewise, people can get their heart rate well above 150 when they're exercising. So it is really important when we're using an implantable loop recorder for syncope to look not just for the heart rates, not just for the arrhythmias, but for symptoms associated with them. And I'm really only saying that to be comprehensive. There is no single way that without patient participation, we can test for syncope or screen for it, or even come up with a definitive diagnosis. Okay, so this is well, you can see it's from 2007, but this was a guy very similar to the first one, but different patient who, after getting comprehensive evaluation, we couldn't find a cause of syncope and implanted a loop recorder. And sure enough, days later, he had a 7-second pause, which turned out to be due to AV block, and he underwent pacemaker implantation. This would not have been possible with any of the provocative tests, and we could not pick it up with an echo, stress test, etc. And these are sort of some of the original examples. If you are doing long-term screening and people have transient high-grade AV block, eventually you can find it. Same thing for non-sustained VT. Head-up tilt table testing. You guys are more expert at this than I am at this point, but I wanted to show you this picture because there is this myth out there that we put people on a tilt-a-whirl and swing them around and get them dizzy. It's actually the most boring test in the world. We sit people up, and I wanted to sort of describe in sort of simple terms what we expect to happen with head-up tilt table testing. In a normal person, and that dotted line represents where we put the table up, your blood pressure will fall a little bit. when you go from supine to upright, but not a lot. And then it'll rally and get back to a steady state. Likewise, your heart rate will go up a few points to compensate, and then it'll come back down and go to a steady state. And for as long as you perform the test, you know, within a few points, it'll remain stable. Here's the thing about vasodepressor events, is they come on fairly abruptly. So you can, the first 20 minutes of a head up tilt table test can seem completely normal. The heart rate's fine, the blood pressure is fine. And then abruptly, the brain says, I've had enough, and it sends out a signal. And it can be it often is fairly abrupt. And for those of you who perform tilt table tests, you can see it coming. The patient will say, I feel sick to my stomach. Is it getting hot in here? I'm sweating. And the next thing you know, they're bradycardic and hypotensive. If you have classic autonomic insufficiency, and remember, these are cartoon diagrams, your blood pressure gradually falls because you've lost that ability to regulate your blood pressure using the autonomic nervous system. And your heart rate, whereas it should be increasing, stays about the same. And this is what would happen if you did a tilt table test on somebody who was just dehydrated. Your blood pressure would fall, your heart rate would go up. Classic orthostasis. The tilt table test has to be a confirmatory test. It has to be a confirmatory test. I might say it 3 times. It is a provocative test. It's not a correlative test. There are false positives. And so the times that electrophysiologists will say, I'm not sure what this person has, let's perform a head up tilt table test. You have to go into it with a clinical suspicion that people have a tendency towards vasodepressor events, because there is a false positive rate. Does anybody know who this is? Yeah, Reggie Lewis. This is a really good example of how not to do a syncope workup, and it's a very famous and illustrative case. So Reggie Lewis was the captain of the Celtics. During the playoffs, while he was playing, he lost consciousness. Got back up, and what did he say to his coach? He said, I'm fine, put me back in. Went back in, lost consciousness twice. Okay, what are you guys thinking when you hear that?
Arrhythmia.
Absolutely. He felt fine afterwards. Okay. You don't, by the way, you don't pass out during athletic competition. You might pass out when you finish a 10K. You might pass out when the competition is over. You do not pass out when you have the adrenaline surge from a vasodepressor event. Okay, bear that in mind. Okay. So after the second episode, he was hospitalized, battery of tests, and did appear, you know, again, this is shrouded in mystery a lot because it's controversial, but he did not have a normal heart. He went to get a second opinion because he didn't like the idea of not playing basketball. And he underwent a tilt table test. And the tilt table test was positive. And a otherwise good cardiologist held a press conference and said, see, he had a tilt table test that was positive. He's fine. It was vasodepressor. And a few months later, he was playing basketball and dropped out. And I think this is a really good point of why correlative tests or why provocative tests are not helpful. Okay. The guy did not, I mean, there was nothing in his story to suggest vasodepressor. It did not sound vasodepressor. And so if you do a head-up tilt table test without knowing why you're doing it, you will come up with a false positive. And the price that Reggie Lewis and his family paid was a dear one. So I'm going to go back to the original guy. So the guy had a 2-second pause on his treadmill test. We yawned at it. We did an echo, catheterization, EP study, all negative. We re-requested the primary data. Okay. What do you guys think of that? This is the guy on a treadmill test. What do you guys think of these? Checking on the chat here. They're P waves. Well, P waves I like, right? That means the atria are working. But they're unanswered P waves, which is bad, right? And so let's just go through this. This guy was booking along on an exercise treadmill test. His heart rate was 149 beats a minute. And abruptly, he stopped conducting. Okay. So this is transient high-grade AV block. This is pathologic. This is not a boring pause. This is not, you know, a little bit of vagal influence. This is not his sinus node taking a break. This is AV block. Why am I showing you this? Because if we had bothered to look carefully at this single strip, the guy wouldn't have gotten a cath, he wouldn't have gotten an EP study, and he would have gotten what he needed in the first place, which was a pacemaker. And I can't remember who said, look at the EMS strips, but the primary data is so important in these circumstances. Let me see if I can. So I'm just going to summarize. I cannot overemphasize that the history is the single most important component. Further tests should be tailored. I think this is really important. If we need to know what we think the patient had, and that will sort of inform what tests we do. Our goal should be to screen for dangerous and preventable causes. Okay. And so we have 1 minute left. Any time for questions?
Chuck, that was really, really helpful. Thank you.
Recommendation on driving? No. So I will give you my 2 cents about driving. And we're going to go over, but this is really, really, really important. The first thing, and I think this is something we should always tell patients, the state of Maine, and by the way, this is not Andrew Corsello or Henry Sesselberg saying it. The state of Maine says, if you pass out, you shouldn't drive for 6 months, okay? Joel won't admit that he helped write the rules. In fact, he will deny it, but it doesn't matter because every state has similar rules, whether it's the state of Maine or the state of Florida. The state law basically says you should not drive for 6 months after you pass out. For better or worse, the studies that have looked at it have shown that people do not follow the rules. People do not follow the rules. So unless you actually call the DMV and take their license away, which we've never done, okay, which we've never done, patients drive. I'm not saying that's right. In fact, I would say it's wrong. But bear in mind that it does that is happening. The best thing we can do, and I can't overemphasize it, is not to impose something on the patient and say, dude, you can't drive, you'll lose your job, all that kind of stuff. Is make them be an active participant. Explain to them why the rules are in place, that they are at risk for passing out and harming themselves and other people, and that you are partnering with them to prevent worse episodes. Now, if people have vasodepressor episodes in general, we don't put driving restrictions. If we are convinced it's vasodepressor and we've educated them on how to avoid it, we rarely place driving restrictions on them. If there are other forms of syncope, we should be pretty firm about it. If it's due to AV block or bradycardia and they get a pacemaker, we usually wait for a month to make sure that the leads are still working, and then we let them drive again. But I think the most important thing is to me is the conversation. You have to make the patient aware of why the rule is there. It's not arbitrary. It's not something you should hide from the DMV, and it's a public health issue. All right.
Okay, great. Thank you so much.
Thank you, guys.
A question about the CME code. Yes, I actually forgot to send the email. So you can send the CME code, but I would wait for another hour. All right. Thanks, guys.
Thank you.